and welcome to the 27th Annual Alamo Advocate Program. My name is Kristen Teig-Torres. I'm a member of the Beyond Pink team, the National Breast Cancer Coalition, and I'm one of this year's Alamo Scholars. It is my honor to present tonight's moment of silence. After being diagnosed with metastatic breast cancer in 2011, Ann Loser became a tireless advocate for the metastatic breast cancer community. To spare patients from the arduous task of researching metastatic breast cancer and its treatments, Ann published The Insider's Guide to Metastatic Breast Cancer, with the intent of delivering accurate, up-to-date information to all patients, irrespective of their location and ability to pay for the book. She provided a complimentary downloadable copy on her website. Ann also authored several articles on metastatic breast cancer. In 2019, she founded the Patient-Centered Dosing Initiative and shared the results of a patient survey about the damage resulting from treatment-related side effects at the ASCO annual meeting. This influenced the FDA to promote oncology drug dosages that are more tolerable and less toxic for individuals being treated for cancer. Ann continued to expand her knowledge of breast cancer and graduated from NBCC's Project Lead in 2019. Ann passed away from metastatic breast cancer on October 10th, 2023. Please join me in a moment of silence to remember Ann. Thank you.
Okay, welcome everybody to the second Hot Topics for the Alamo Advocate Program 2024. My name is Jonathan Colmier. I'm the Executive Director for Alamo Breast Cancer Foundation. I am also proud to serve on the committee that organizes the Alamo Advocate Program. I've been involved with the family of Alamo Breast Cancer Foundation for about 10 years now. Very happy to be here. Just want to welcome everybody here tonight. We know that the Hot Topics are awesome. Everybody enjoys this. It's going to be fun tonight. We're going to ask some questions. I will remind everybody, for the questions online and in person, please limit your questions to not your own personal medical background, your own personal case. Let's keep it generalized and germane to the symposium presentations that were presented today. So I'd first like to acknowledge our sponsors who make this program possible. Without them, we would not be able to do this program. Genentech, premier level sponsors. We've got Genentech, Menarini Stemline, Pfizer. Collaborating, we have Cybermedia Productions, Daiichi Sankyo, Exact Sciences, Lilly, Merck, Novartis. And contributing level, we have GE Healthcare and Natera. Patron level, we have Viatris. And supporting level, we have Eisai. Can I get a round of applause for our sponsors? Thank you so much. Okay, so this evening, each of our four mentors will spend about 10 minutes highlighting what caught their attention at today's sessions. After that, we're going to open the floor for questions. Remember that we're focused on what was discussed today. Like I said, keep your questions focused on today's proceedings, if you would. So it's my honor at this point to introduce our mentors. Please refer to the biographies in the speaker section of the Zoom Events app for more detail if you want to learn about their careers and what they're doing in the breast cancer space. Dr. Jenny Chang, the Executive Director of the Houston Medical Neal Cancer Center, holds the Emily Herman Presidential Distinguished Chair in Cancer Research. She's also a professor at Weill Cornell Medical School. Her recent work has focused on the intrinsic therapy resistance of cancer stem cells and the role of targeting inflammatory pathways to change tumor immune microenvironment. Welcome, Jenny.
Thank you.
Dr. Mariana Chavez McGregor, professor holding joint appointments in Health Services Research Department and Breast Medical Oncology Department at MD Anderson. She's both a clinician and a researcher. Her program focuses on studying patterns of care and outcomes with and emphasis in disparities. She has extensive experience evaluating cancer care delivery, toxicities, and complications of cancer treatment. Welcome, Dr. Chavez. Dr. Debbie Tripathi is a professor of medicine and chair, Department of Breast Medical Oncology at MD Anderson. His clinical research focuses on the evaluation and development of novel therapeutics in breast cancer, specifically those targeting sensitivity and resistance mechanisms to growth factors, endocrine modulators, and cell cycle control pathways, as well as biomarkers that predict sensitivity and resistance. Get a round of applause for our panel here. Thank you so much for joining us. So let's start with Dr. Chang. What was hot today?
Well, there were a lot of hot things today. I think, if I was to summarize it, I think we're getting to know a lot more about breast cancer. And that breast cancer, just because it originates in the breast, is many, many different types of disease. And in particular, are there ways in which, to be very honest, as you heard from Ann Losa, she tried to de-escalate treatment. And we tend as oncologists, not only to combine therapies, but we escalate to the maximum tolerated dose of combinatorial therapies. And that Bill Kalin today, he gave the keynote. And he was saying that we've got to be smart about how we combine drugs. And we've got to think about the biology, the genetic alterations within the tumor that may make it necessary, and how do we combine these treatments and de-escalate. Not everybody needs chemo, and those that need chemo may need more chemo, and we have all these different drugs that we have out there. And so I'm combining a few things from Bill Kalin's talk, which I thought was extremely interesting, looking at Laura Van Veer's talk, where she's looking at all the different genomic subtypes. And in my mind, I think we're close to being able to de-escalate treatments for select people, especially in the HER2-addicted tumor space. So patients with HER2-addicted tumors may not need all this chemo that we're giving them. There were a few studies which I thought were terribly exciting. One of them in the neoadjuvant early HER2 space, where they gave 3 cycles of chemotherapy with the HER2-targeted therapy and then stopped. And in patients with a imaging complete response, they never had to finish off their chemo. They continued the targeted therapy, went for surgery, and we had a very high, very, very safe, high pathologic complete response. So can we de-escalate chemo in patients who have had a great response, and is 3 enough, or even, as Eric Weiner was saying, 1. If you get a great response after 1 dose, can we de-escalate? Other studies that show about de-escalation, other than using MRI as a predictor, were again, a fascinating study, again, with HER2. If you're HER2 positive and you're hormone receptor positive, they showed in that study that if you gave HER2-targeted therapies and ER-targeted therapies, it was the same as giving HER2-targeted therapies and chemotherapy. So again, we take away, obviate the need for chemotherapy in these select patients by giving them both ER-targeted and HER2-targeted. And obviously, I would be amiss not to mention the quickfire by Polly Naravath, which is from my group, where she looked at a HER2-enriched subset of HER2 breast cancer patients. This is very, very HER2-enriched, meaning that these tumors are addicted to HER2. And by giving HER2-targeted therapies and immunotherapy, the PCR rate, the path complete response rate, was in 60–70%. Super high, and these patients have no hair loss, no nausea, no vomiting, no immunosuppression. So we're getting to understand breast cancer isn't one disease, and we are now smart enough to know the genomic alterations that drive, especially in the HER2 space, so that we can de-escalate, either because you have such HER2-addicted tumors that you do not need chemo at all, like in Polly Naravath's study, or give a few, and then if you get a great response, stop. Or if you have both HER2 positive and ER positive, maybe you don't need chemo. Maybe we can use a combination of both HER2 and hormone receptor targeting therapies. I think that we have so many new treatments. We know what drives some of these cancers. We understand the alterations, as Laura was saying, Laura Van Veer. So it's time to be smart. It's time to give the right treatment at the right time and only escalate if and when we need it.
Thanks, Dr. Chang. Dr. Tripathi, what was hot today?
Well, I was going to talk about endocrine therapy because the estrogen receptor and the hormonal stimulation of estrogen through the estrogen receptor is a big contribution to breast cancer. However, the estrogen receptor is also seen in normal tissue, and it's an important part of normal biology and the normal health of the tissue. There's been a lot of increased in our understanding as to how estrogen receptor can drive breast cancer. And when you think about it evolutionarily, breast cells normally grow in the presence of estrogen, as do uterus cells and others. And because cancer is survival of the fittest, and random mutations that happen to give a selective advantage are the ones that end up winning out, so that when someone actually develops cancer, you already see these mutations have already developed. And one of the ones that we see in estrogen receptor positive cancers are mutations in the estrogen receptor, and we tend to see them in patients who have been on endocrine therapy already. And so we have taken advantage of this by designing newer drugs that can overcome resistance to endocrine therapy. And there was an interesting update on one of the drugs called imlunestrant. And this is one of several drugs that's being tested to see if it can be superior than what we use now, which is either tamoxifen or a class of drugs known as aromatase inhibitors. So this study, known as the EMBER-3 study, was presented last night, actually. And no, it was actually presented this morning. And it was a study in which patients who had already progressed and had developed metastatic breast cancer and had been on hormonal therapy before were randomly assigned to one of three groups. They either got the standard aromatase inhibitor therapy, or they got aromatase inhibitor therapy with the drug imlunestrant, or they got a third arm that they added later, which was imlunestrant and abemaciclib. So what they showed is that their new drug, imlunestrant, that is supposed to work against the mutated estrogen receptor to a greater degree, was about the same as the standard aromatase inhibitor in patients who did not have the ESR mutation, which was about 20 to 30% of the patients, which was explainable because they had already been on endocrine therapy. However, imlunestrant was better than aromatase inhibitor in patients who did have an ESR1 mutation, and there's already another drug that's approved for that situation. But I think the important finding here was that the addition of abemaciclib, and again, these are all patients who had already progressed on a cyclin-dependent kinase like abemaciclib, but a different one, and that arm actually did better. So what it tells us is that we maybe can use these new SERDs, selective estrogen receptor downregulators, which is what imlunestrant is in that class, and in addition to a different CDK inhibitor, they tested abemaciclib in particular. So this may establish a new standard as to how we treat patients with these drugs and be able to continue therapies without introducing chemotherapy, which is something we use when we can no longer get a response from hormonal therapy. And I'll add that the field of hormonal therapy is undergoing a revolution in other drugs as well, not just these SERDs, so to speak, but there's a new class of drugs that can degrade the estrogen receptor much more potently. There's a drug called vepdegestrant, and there's another one called palazestrant, and I don't know why they name these drugs with tongue twister names. But those are drugs that are being tested in as well. They're in earlier phase studies right now. So we expect that we're going to be able to get much more mileage out of endocrine therapies, but we also know that we have to combine them with targeted therapies because one of the mechanisms of resistance is these pathways. Many of them are from growth factor receptor related pathways, and we can block these with newer drugs as well as cyclin-dependent kinases like abemaciclib. So the future of this area is that we are able to monitor patients, see when they develop these ESR mutations, accordingly change their therapies, but also introduce newer endocrine therapies and newer biological therapies that will allow us to keep therapies less toxic. So it's an important advance, and I think we're going to be seeing more as we discover much more about the biology of endocrine resistance. But it is the oldest therapy that we've had for breast cancer, actually dating back to the late 1890s, when oophorectomy was found to help patients, and we've come a long way since then.
We sure have. Thank you, Dr. Tripathi. Dr. Chavez-McGregor, what was hot today?
Well, I want to start by thanking you all for having us here. It's really a highlight of the meeting, and I think it's something that to all of us keeps us grounded and motivated, because you guys are the reason that we do what we do. So thank you for having us and for inspiring us every day. Regarding the meeting, it's early in the meeting, so there's still a lot to come, but I will think about what we've heard in two different ways. We have the educational sessions, and we're having new data presented. The educational sessions, I think, are always incredible reviews by world experts in certain topics. Yesterday, it was not today, but yesterday, there was a session called Sex, Drugs, and Rock and Roll that I think you all should go back and listen. It really talk about key things that I discuss every single week in my clinic: supplement, diet, sex, alcohol, can we have a drink, diet. So I think those are things that the field is growing and getting educated about this day-to-day topics. It's important for you and for us. At the same time that this session was going on, there was another session that was touching on obesity and the importance on, trying to avoid being overweight and exercise. So I will invite you all to look at those sessions if you were not able to be there in person. In the educational sessions, I think today one that I really enjoyed was the one that was discussing antibody drug conjugates, or ADCs as we know them. These drugs are part of the standard of care for patients across all the breast cancer subtypes. We have a lot of issues and challenges regarding how to sequence them. The algorithms, as you know, are changing because we get new data. So it was a very interesting session, really highlighting where the field is going, even touching on new drugs and how we're trying to understand the resistance that unfortunately, the tumors develop to these drugs. Now, on the novel research, right, like the things that we hear at the plenary session, we had the general session number 1 today, and I think there were some presentations in addition of what my colleagues presented that were very interesting. There were 2 presentations in the subgroup of patients with BRCA1 or 2 mutations. So you all know that this represents about 5 to 10% of patients with breast cancer. There's this gene predisposition, abnormalities, and now we know that there are certain drugs that can help us. Those drugs are PARP inhibitors, and there is a very important study, the Olympia study, that evaluated the use of one of these drugs, olaparib, in the adjuvant setting. We're talking about patients with early stage breast cancer that after completing their treatment receive 1 year of olaparib, trying to reduce the risk of the cancer coming back. This is a positive study, we knew that, and what was presented today was the updated analysis with even longer follow-up. So with even longer follow-up, now we know that giving 1 year of olaparib to patients that have high-risk tumors with BRCA1 or 2 mutations, that have triple negative or hormone receptor positive tumors, reduces the risk of recurrence and helps patients live longer. And I think it's a very important message that we have more options and how crucial it is to test our patients. Because now it's not only I want to know or I don't want to know, or maybe I don't have siblings or I don't have offspring. This knowledge can give us more options to treat our patients better. Along the same lines of patients with BRCA1 or 2 mutations, Matteo Lambertini presented data from an extraordinary collaboration around the world where they received information of 5,000 women with BRCA1 or 2 mutations that had early stage breast cancer. And then what they just asked was whether they underwent a contralateral prophylactic mastectomy or not. Because as you know, that's something that we might discuss, I might recommend, but not all patients decide to do it or can do it. And what they confirm is that those patients that underwent a contralateral prophylactic mastectomy live longer. There's a lot of uncertainties about the data because it was questionnaires and retrospective data that was collected, but it tells us that maybe we can do another intervention. And while I'm not saying that contralateral prophylactic mastectomy is something easy for patients to agree on, it could also be an intervention that can help patients live longer and not develop subsequent cancers. So I think those are very interesting presentations in that space. Something that I think it's very interesting, and it's early because we just heard 10 minutes of the presentation, but it was a presentation from German group. A study was like the Pro-B trial, I think that was the name. So patients with metastatic breast cancer in Germany, about 800 of them. 400 receive usual monitoring of symptoms, and the other 400 receive some sort of like text messaging way to communicate with their provider. So they were assessing what we call patient-reported outcomes, more real-time, how are patients feeling, and trying to intervene early. And they did it through text message. So maybe more easy to access than going on my chart and my basket and all that kind of stuff. And what they, right? I guess we all have used it. But what was fascinating is that those patients that had that potential easy intervention to access, they measured fatigue, and they had less fatigue. And whether they had less fatigue or is that there were ways to manage the fatigue, and granted we're not great at helping the fatigue, but maybe there's dose reductions, there are different things that can be done. So patients that were on this patient-reported outcome communication, and patients were on chemotherapy, a lot of them, so it's not that they were only on aromatase inhibitors, right? They were on chemotherapy, they had less fatigue. And interestingly, and very controversial, and we're going to have to see the full manuscript, patients that were on that arm live longer. Live longer. And it's like, what's the mechanism? And that's something that the discussant tried to address, and the questions did it. And, could it be that by addressing fatigue, we're able to have patients stay on treatment longer? Maybe, right? Maybe we're able to give them, I don't know, more quality of life also. So I think those things are very interesting. They are really being implemented in a number of settings, how to communicate with our patients in a more real time to really intervene. The thing that I sometimes tell my patients, like, I don't want you to come in 3 weeks and find out that you had to go to the ER, right? Like, I want to know early, because maybe there's something that we can do to avoid that. So anyway, I found that fascinating, and I think it's probably going to be something for all of you to look into, because very interesting.
Great. Thank you, Dr. Chavez-McGregor. Appreciate that. Okay, so now at this time, we're going to open up the floor to questions. I would ask that anybody in the room here that has a question, go ahead and line up behind one of the microphones. Those watching us online, please submit your questions through the comments section on the app, and we'll get started here. Do you have anybody with a question?
We know you guys are not shy. Come on.
Oh, and I would remind everyone, again, please keep your questions germane to today's presentations. Please don't ask about stuff that was presented yesterday. And keep it general, not personal medical history kind of stuff. If you have questions about that, we can maybe chat about it afterwards. So.
Hi, my name is Maria Boyce. I'm with Alamo Advocate Program. I'm curious as to whether any of you attended the program about how to define triple-negative breast cancer. I thought it was really interesting, the idea of, do we include or not include HER2 low as we define triple-negative breast cancer, and what does that do to our prior studies and our future studies? Would love your thoughts on that presentation.
I attended it. I don't know. Were you guys there?
No.
I was there. Great presentation. One of those educational sessions. It was today, I think 2 to 3. And it was about triple negative. And it was a very interesting discussion about how triple negative has really been a diagnosis of exclusion, right? Those are tumors that are not ER positive, not PR positive, and that do not overexpress HER2. So this sort of like leftover basket. And the main question was not only about HER2, it was about ER low. So as you know, we have historically defined estrogen receptor positivity as 1% or more. But that leaves us a big, space from 1% to 100%. And we know that there's a spectrum and that probably correlates with response to treatment. So for years, we've wondered what to do with the low ER. So those patients that have ER 1 to 9% that biologically are more aggressive tumors. And we know that biologically behave more like triple negative, but since they have a little bit of the ER, don't fit into that, strict definition. So there was a lot of, very interesting conversation as of what does that do to our clinical trials, because we don't want to limit, or we've been actually trying to not be too restrictive to give options to our patients to enroll in the trials. But at the same time, if we allow those patients to be enrolled, we might have more heterogeneity on the clinical trials, and then the interpretation can be harder. So it was just like a very interesting discussion. I think we're learning that it's a continuum and that there's a lot of heterogeneity, and that probably what we have to do is to individualize. Even ASCO and the College of American Pathology on their latest guidelines, even if they continue to have this definition of ER 1% as positive, there's this category of low ER. In that case, it's 5%. But it is something to really, and I think that we think about that in clinic a lot. Don't you all think that, we have a patient that has ER 9%, well, maybe we want to treat her with, a triple negative like regimen. So I think we all struggle with it.
Yeah, it is, we don't know exactly where to draw the line, and there may be better tests that give us that answer that use multiple gene analysis. And then just very quickly to answer your question about HER2 low, triple negatives can be HER2 low. It means that they are truly HER2 negative, but they make a little bit of HER2. And why that matters is that while we wouldn't use HER2 targeted therapies because they're not HER2 positive, we can use the antibody drug conjugate known as Enhertu or trastuzumab deruxtecan, because that works in HER2 that's only 1+, which is still technically negative. So I just wanted to mention that since you had brought that up with your question.
Yeah, so the HER2 loads are not truly HER2 addicted tumors. They're not, the pathway is not activated, but there's enough so that you can bind. It's more like a linker. It's something that just to anchor the drug onto. So biologically, I don't think HER2 lows fall, into a distinct genomic alteration entity. So it's slightly different. It's more as an anchor. But I too struggle with the ER low. I think that's one of the really, it's a continuum. It's hard. Do you give endocrine therapy? Do you not? There will always be something. But I think, again, Van Deer's data, I think we're moving away. We're moving away from just IHC. We're going to have to use these multi-gene things to inform how we treat our patients.
And I think as physicians, and of course in partnership with our patients, at some point we have to make a decision, right? We cannot treat a patient with, let's say, ER 5%, all like triple negative, and then want to do something like if they were hormone receptor positive. Like I think at some point we have to, commit to certain therapeutic approach. And I also think that the trade-offs are very different in the adjuvant setting than in the metastatic setting, right? Yes. Maybe in a patient with early stage disease, we might say, yeah, even if we don't know if it's going to help a lot or not, let's try to add an aromatase inhibitor. Whereas if there's a patient that has very aggressive features, that might not be a patient that we want to treat just with that in the metastatic setting. So I think also the setting that we're treating our patients in makes a difference.
Great, great. Next question.
Hello, I'm Natalie Belcher. I'm an Alamo scholar and with the Delaware Breast Cancer Coalition. Dr. Ching, you made a comment, very brief, about MRI. You mentioned
Yes.
MRI. What I want to know is, were you saying that, or suggesting that MRI should not be used as a determinant, or were you suggesting that and I know Dr. I'm sorry, Dr. Jody, you said
Duplessis.
something about de-escalating chemotherapy or de-escalating types of approaches and therapies.
Yes.
Is MRI not valid any
Very
longer?
good.
Is that what you were
No,
saying?
the study was that they gave, so traditionally we give 6 cycles of chemo plus targeted therapy. And as we know, 6 or 8 cycles actually, to be honest. And towards the end, I mean, a lot of patients, a lot of you guys in this room, you know it's tough. I mean, your hair and you're feeling fatigue and infections, etc. So the study was actually very, very smart. Instead of giving 6 or 8, at 3 cycles they did an MRI. And when they showed that the cancer went away completely, they dropped the chemo. And it was just as good.
Great. Next question. Oh, any other comments from our panel? Nope. Next question.
Elisa Shirago from the IBC Network Foundation. And this has been so helpful. Thank you so much. This is my first time here. I did have a question about the new drugs relating to endocrine therapy. Is it possible, foreseeable, that they may take the place at some point in time of aromatase inhibitors or tamoxifen?
Yes, I think they will. What's important here is what you start with and then what you use if resistance develops. As a starting point, it looks like tamoxifen and aromatase inhibitors are roughly equivalent, but aromatase inhibitors are just a shade better, both in the early stage setting and in the advanced stage setting. What's more important is that we, especially for advanced breast cancer, we don't use hormonal therapies alone anymore. We combine them with cyclin-dependent kinases in the first line, and then with other biological therapies later. And also, when people become resistant to endocrine therapies, as I had mentioned earlier, there are some newer endocrine therapies that are being tested. And I suspect that, to answer your question, is in the advanced stage setting, we are going to be moving to these newer estrogen estrogen receptor targeting drugs, such as Protax and complete estrogen receptor antagonists that are more potent. So I do think we're going to see a shift in those in our use of those drugs.
I would like to add, if I may. So at the moment, these drugs are, other than today's, for ESR1 mutated tumors. So, and that occurs after you've been on endocrine therapy. So in the early breast cancer setting, at least not today, they will not be used if you have early adjuvant setting. It's not yet indicated in that setting because you have not acquired a mutation as yet. Just wanted to clarify.
And there are studies that are looking at that to see if they're better than the standard either tamoxifen or aromatase inhibitors that we use now. So there are studies ongoing now in the early stage setting, so that may change, but I agree with Jenny for now, current time.
Great. Next question.
Hi, I'm Christine Carpenter with Cedar Valley Cancer Committee, Beyond Pink team in Iowa, and the National Breast Cancer Coalition, and I'm an Alamo scholar. Thank you, Alamo. This is not a personal question because it doesn't pertain to me, but it does to my friends. And that is, you talked about, the ER positive, maybe just, and HER2 positive having just like an AI and her Herceptin type drug, and foregoing the chemotherapy. But what I wonder is, will insurance pay for this? I mean, these newer drugs are very, very expensive. I hear, and so will insurance pay for that? And how will we deal with the money that it costs? I go to the exhibit and I see these huge, expensive things, and I think, no wonder the drugs cost so much. Displays. So I guess my question is, are we going to be able to afford this in the U.S. and Europe and Africa and Asia and places like that?
I agree. I think financial toxicity is one of the huge, things that we have to deal with as a society as a whole. I'm passionate about that. I think that is one of the, and back to the ER positive breast cancers and de-escalating. These are the reasons why we do it. So some of the new drugs some of the drugs, like for example, the MRI midway stop, that's a great de-escalation. It's not going to add any cost. In fact, I think it's going to save money. And, so not everything is a new drug that needs to add costs. And we need to be very careful. Combining more and more new treatments may not be the way that we do things. A good example is in the adjuvant setting. So after you finish your neoadjuvant therapy and you get a great response and you've got a pathologic complete response, we just continue. We just continue the same, immunotherapy or drugs after that. There may not, we have studies now to see whether we really need to continue those drugs. So I think we're getting smarter, I hope, and more cognizant of the fact that this is huge financial toxicity. And the way we treat medicine doesn't always, in America especially, it's not always the right way to do things, I personally think. And excess is a huge deal in this country.
Yeah, I will add that you're absolutely right. Some of these drugs are incredibly expensive. In general, once the drugs are FDA approved and their use has been incorporated to our guidelines, either ASCO guidelines, NCCN guidelines, we can use that as a support, a very strong support document to different payers to request the coverage. And in general, I will say that for most of the scenarios, as long as we stick with standard care, and luckily we have extraordinary options, standard care, we do get insurance covering the drugs. Now, of course, there's other issues like the copays that sometimes can be, incredibly high. That then, even if the drug is covered, it's putting our patients into a very, complicated financial situation. And I think more and more we're hearing about it. Not only from our patients, from their families, but also, there's a big group of now researchers and experts are trying to measure it and to actually address it. To your point about what happens in other countries, you're absolutely right. We know that there's a big disparity in the way that patients with cancer are treated in the world and even within countries because there's a wide diversity of resources. And I think with better treatments, what's potentially going to happen is that the gap, it's going to get wider, right? Because here we are talking about the importance of, genomic testing and molecular testing and all these things that today help us make decisions for treatment. But there's places where they can barely do HER2 testing, right? So I think that that is something that we should recognize. And when I go and give talks in different parts of the world about like this great drugs, I do acknowledge that I practice in a very privileged setting where I can prescribe all these drugs to my patients, whereas not everybody can do.
Great.
Hi, thank you. I'm Kirsten Spencer from Met UK in England. I'm an Alamo scholar and NBCC and GRASP and a few other things. So I want to get back to that general session this morning, which I found brilliant and very, very exciting. But I had to say I had a little bit of an eyebrow raise because I was looking at, and admittedly he said this isn't terribly scientific, and he did a cross-study comparison of all different drugs, imlunestrant obviously being one of them. In that cross-study comparison, I saw lovely lasofoxafen, been around for decades, fantastic drug. So, and it outperformed imlunestrant as a monotherapy straight away, no problem. But then he was looking at them all in comparison to imlunestrant and abemaciclib. So that reached 9 months. Now, on another slide, I saw lasofoxafen and abemaciclib. Over 12 months progression-free survival. I was like, my God, why are we not swinging from the chandeliers, raining people with lasofoxafen? Cheap drug, excellent profile, toxicity. what do you think about this? I'm so excited. I'm off to Portugal to buy some.
Well, lasofoxifene is an
great.
interesting drug. It's been around for a long
Yep.
time. It was initially tested as a prevention
Prevention
drug.
drug.
And it was a
osteopenia,
positive
wasn't
study,
it?
but the FDA didn't approve it because it did lead to a slightly higher risk of blood clots, like tamoxifen does, because it's in the same class of drugs as tamoxifen. But it is an important drug, and now it's being re-examined because it may have some activity against these ESR, estrogen receptor mutant cells.
Y537S, they found it works.
Exactly.
Yes, that's exactly right.
And in the Elaine 1 study, very good,
Yes.
you know all
You,
that. In
you
the
do know
Elaine
the
1
Elaine
study,
one study too. Very good.
in the Elaine 1 study, it was better than aromatase inhibitor therapy. And then in the Elaine 2 study, when they combined it with abemaciclib, that was the one that had the really high bar.
Yep.
So the Elaine 3 study now is going to be looking, it's a randomized study that is going to compare lasofoxifene to standard aromatase inhibitor therapy with a CDK inhibitor. And that will open up a new avenue. Now, here's going back to the cost issue. It's going to get repurposed by the FDA and given a new patent probably for a new use. So the price of it would have been dirt cheap as a prevention drug.
Yeah.
It'll probably go up again unless something happens. There may be an outcry against it. But
So we all need to go to Portugal and stock up.
so you might need to go to Portugal anyway, and and get a very nice bottle of port while you're there too. And,
Absolutely.
and you might not move back, but until 4 years from now. But I shouldn't say that.
Oh, you slipped it in.
Guilty as charged. Guilty as charged.
You are in Texas.
Oh my gosh.
Sorry.
Thank you, Kirsten. Excellent question.
But yeah, LACE was a very interesting drug. It was like Trevor Poles was the first to use it in the chemo prevention, and that's why the Brit knows about it. So those studies were done in Britain. Trevor was my mentor many years ago.
Yep. So we're going to take a question from our online viewer now. Combining information being discussed with regard to utilizing circulating tumor DNA and endocrine therapies targeting ESR1 mutation, has there been any information to indicate patients can de-escalate from using elacestrant it's a tongue twister, back to a combination of an AI plus a targeted therapy if other actionable mutations are present and ESR1 has resolved?
Oh.
Good question.
I don't think ESR1 resolves, does it?
I don't think
It
I don't think
sometimes
so.
will get extinguished. If you look at serial circulating tumor DNA, you'll see the amount of
less.
ESR1 go down, but it's
possible.
still there. And the minute you take it off, boop, it'll pop back up. So I think the answer is, I can't say for sure, but we wouldn't
would
design a
agree.
trial like that because the likelihood is that it'll come back.
And it's not because it's gone away, it's just the fraction of cells with the ESR1 mutations being controlled by
But the drug, right?
by the drug, and then after that will come back up.
It'll come back up, yeah.
Great. Next question from our audience here. Hi, Michelle.
Hi, Michelle Tregear, National Breast Cancer Coalition and patient advocate. I had a question about the EMBER trial. So I thought that was interesting. Had some questions about the design, but I was really interested when Hal Burstein got up and presented the follow-up on that. And so I'm curious what your take is on the overall survival sort of negative signal that they saw, that he showed, because that wasn't in the previous, in the actual EMBER presentation. So it was, I mean, there was definitely a progression-free survival benefit for abemaciclib with the imlunestrant, but it looked like there was a detriment. And I know the overall survival data was early, but it didn't look like it was going to change a whole lot, or if anything, it would be equivalent. So I just wonder what your thoughts are on that. And also, again, sequencing a drug that is really kind of targeted for an ESR1 mutation in a population that at least was mixed.
Right. So you're right. It was a mixed population. These are patients who had already progressed on an aromatase inhibitor plus a CDK inhibitor, and so many of them probably at that point will develop an ESR1 mutation. And so they were looking at progression-free survival, which was definitely better. But you're right, the overall survival was about the same. I mean, it might have been slightly lower, but the bottom line is it is too early to look at a survival advantage, because all it takes is 1 or 2 events and it'll switch. You need longer follow-up to analyze survival, but it is something to keep an eye on. When trials are designed like this, there's a data and safety monitoring committee that is periodically looking at the data. And these are independent people who are asked to sit on the DSMB that are, have no allegiance to the drug company or anything like that. They're supposed to be independent. And they look at it, and they may stop a trial if they feel that the statistical, and usually the statistical rules are written ahead of time. It'll say if this boundary is crossed in terms of survival being worse, stop the trial. But if it only transiently goes differently, where it can again reverse, then we'll let it go out. So that's probably what's happening, but it will be followed closely at subsequent analyses to make sure that it does eventually show either a benefit, or it may show no benefit in survival, but still a progression-free benefit, which would still be useful. But I think that remains to be seen. It's too early to conclude anything.
Can I just go ahead. Go ahead.
What I will add regarding the results that I found very interesting is, as you know, Dr. Tripathi mentioned, this class of drugs, the SERDs, we're learning that they're very active, or particularly active in this roughly 40% of the patients that develop ESR1 mutations, right? That's the indication that we had for elacestrant. Well, in the trial that was presented this morning, imlunestrant as a single agent was beneficial only in the patients that have the ESR1 mutation. However, the results in the combination were different, because when the drug was combined with abemaciclib and they were analyzing the patients with and without the ESR1 mutation, both groups benefited, telling us something that maybe when these drugs are combined with something else, maybe helps overcome some type of resistance. So I thought it was very interesting. I think we need to learn more. The manuscript just got, published today. Of course, I don't think any of us have had time to, take a look at it. But I think it's very interesting because it changes the idea on how a lot of our drugs maybe have different use when they're used as a single drug versus combinations.
I guess I was just wondering, because how do we know that wasn't just due to the abemaciclib?
You do not. But you do not actually. That's you're correct. And most people on palbo and ribo, nobody was on abema, very few. I wanted to reassure you about one thing though. In all the years, and please correct me if I'm wrong, there are no drugs that I know of, or trials that I know of, that have shown an improvement in PFS that has resulted in a detriment in OS. So it may be no benefit, or
no benefit.
No benefit can happen, but not a detriment. It doesn't get worse. So it's probably too early rather than...
But you're just saying in breast cancer.
I'm talking about breast cancer.
Yeah, only breast cancer.
I only know
there
breast
are other
cancer.
examples where that's...
No, nothing. I don't know anything about breast cancer. Sorry.
I don't know anything that is not breast cancer.
Yes. But do you know of anything that has an improvement in PFS and yet has a detriment in OS? No, right? No benefit, yes, but no detriment.
I would assume that there are some studies from other cancers, but
not for breast.
But not for breast that I know.
But to your point, correct me if I'm wrong, back when the FDA was evaluating the FDA approval for abemaciclib in the adjuvant setting. So Verzenio in the adjuvant setting, the Monarch E trial.
Yes.
If you guys remember, there was a first wave of approval on a very small cohort. Right. And the reason that the bigger cohort did not get the indication, it's because there was a transient, difference in the curves. The overall survival curve was looking like if it could have a detrimental effect. And thinking about safety first, the FDA waited until the overall survival data was more mature, making sure there was no detriment, and then now we have a more expanded label. So I think you're right. I cannot think about any
very transient.
Yeah, very transient. But I cannot think about any trial that because I don't think we will be using them, right? Like if affects negatively overall survival, I don't think we will be
And most
using.
analyses now are done in what's called a hierarchical analysis, that if you don't meet the first endpoint, you can't even analyze the second endpoint because of the way the statistics are designed.
Right. Okay, we're going to take a question from an online viewer here. One of the posters today was out of the University of Sydney by Antonia Pearson. It was on vaginal estrogen and patient adherence or desire to use them. Many doctors will not give them to patients who are hormone positive. Do you know of any of the studies on vaginal estrogen use and cancer recurrence?
So there are a couple of small studies that have been published. They're not big enough to exclude a tiny risk, but they do not show a worsening of recurrence or mortality with use of vaginal estrogen that is done in a specific way. That is used at the lowest dose possible, and either topical estrogen or the E-string, and used for the lowest amount of time possible to manage the symptoms. The studies are small and the follow-up is short. So not to the level that we would generally change our policy. However, I think many of us are doing this on a case-by-case basis with our patients, that when they have really disabling symptoms of vaginal atrophy, vaginal dryness, trouble with intercourse, that is really disruptive, that we will, at least I will, be okay with a brief exposure of either topical estrogen or E-string, and to manage that very carefully. And also to let the patient know that the level of data is not super strong, that at some point it may be found to be harmful. And then I'm okay with it. But a lot of doctors don't want to take that risk, or maybe don't know the data, or just, it's just a forbidden thing. But that's at least my approach.
This was discussed briefly in that session yesterday that I told you, sex, drugs, and rock and roll. And there was a meta-analysis presented that suggested no increase in risk. Now, part of the controversy and what sometimes causes us disagree with some of our gynecology colleagues is that they said that historically, giving vaginal estrogens will not increase the levels of blood estrogen, right? That if you then check estradiol levels, they're not going to be higher. Some of the issue with those studies is that the assays used to measure were not ultra sensitive. So, there's a threshold of what tests can measure. So if the tests are not very sensitive, maybe there's some slight increase that we cannot capture. Now, just like Debu, I try to have very open dialogue with my patients talking about vaginal lubricants and vaginal moisturizers, because they're two different things and patients need both. Aromatase inhibitors cause much more vaginal dryness, and sometimes I will stop the aromatase inhibitors, put my patients on tamoxifen. If that does not solve the issue, while on tamoxifen, I actually feel much more comfortable for my patients to receive vaginal estrogen, right? If you think about it, we give tamoxifen to premenopausal patients that have functioning ovaries. So if there's going to be any absorption, I'm much less concerned. But we try to do that in what we call pulses. So you do kind of for a little bit, the epithelium of the vagina improves, and then we stop the vaginal estrogen, and then when we really need to, we just try again.
So I wanted to bring up a point. So Mitch Dowsett, again, a UK proponent, so he is an endocrinologist, so he measures the ultrasensitive estrogen levels in the plasma. And when AIs came out, so he measured all this very carefully, and I'm comfortable too, is that initially, when the vagina is very atrophic, there is a slight surge, a slight increase in your plasma estradiol, but that after you re-epithelize the vagina, those levels come back down again. So I'm comfortable for giving it again for a brief period of time. And there is quality of life. I think that's critical. I think all very experienced medical oncologists in treating breast cancer patients recognize this. And I think most of us are comfortable with counseling and for an abbreviated period of time working with it.
Question from our in-person audience here.
Beth Emery from Alamo Breast Cancer Foundation and National Breast Cancer Coalition. I went to the keynote this morning and I was just blown away. Dr. Kalin is such an incredible teacher. I mean, the way he described everything was just so clear. He did talk sort of about what he thought would be coming, which is the future of chemotherapy or targeted therapy would be drug cocktails like
Yes.
we have in AIDS. And the thought occurred to me, how do we do the trials for that when all the drug companies want to only test their drugs with their drugs? Do you have any thoughts about how that's going to work in the future? What are we going to be able to do to actually get to the point that we can put combinations together and have trials that show whether they're effective or not?
So yeah, there are ways we can do combination studies. If the drug's approved, then it's easy because the study sponsor will pay for both the drugs, they'll cover their own drug, and then they'll buy the other drug that may be a competitor's of theirs, but they'll buy it. And so you can do it that way. Now for 2 unapproved drugs, it is complicated. And sometimes we want to study 2 unapproved drugs that are both investigational, and that can only be done if there's a collaboration between the companies, which sometimes happens, or if a third party does it, like a cooperative group that is NCI funded, or the Translational Breast Cancer Research Consortium. So it can be done, but it is complicated and difficult, and probably all of us have gone through gyrations trying to get that done.
Are there things that the advocate community should be doing to try to make sure this happens? Because I look in the studies that aren't drug company sponsored seem to be pretty small.
Yeah.
They're sort of in academic centers, and what should we be doing to make sure that we really are looking at these things in the future in a way that focuses on total efficacy as opposed to my drug with my drug?
A couple of things I can think of. One is, if you're active on social media, just get the awareness out. I think the more people that are aware, the better. Secondly, there's 2 general groups of people I think that need to be talked to be convinced. The medical community, the doctors themselves, the investigators, but also the people that represent you in Congress. They have a considerable amount of influence, especially if a large group or an advocate group comes together to talk to them and to meet with them. I think those are important things. Be engaged. You are all here because you're engaged, and we support you. We will go to bat for you too, but it's really more forceful when it comes from you as one of their constituents, and something that means it's a life and death matter for you. So I applaud your interest in it, and that's an important question to ask, and there are things you can do about it.
Something that I will add is, as Dr. Tripathi mentioned, the cooperative groups are key for this, and these are NCI-sponsored groups that can answer questions that pharma companies are not interested in answering. And to that, I think sharing with legislators the importance of continuing to funding the NCI, it's key. Because we all know that research saves lives. And if those type of trials get defunded, there's going to be relevant questions that we will not be able to answer. The other thing is that through groups like ASCO, for example, we know that our advocacy groups with engagement of patient advocates are having a lot of success by sharing stories, right? Like when it's the story, when it's personal, when it is, this is what happened to somebody that couldn't get into X drug, right? Because those stories are very powerful. They connect the emotions, and sometimes that's what we need to do to get our message out. I know that some of you actually here in the audience and through this group have done extraordinary advocacy group to actually changing the legislation in Texas and giving patients access to testing. That was actually my gift from one of my patients that's sitting in the room for Christmas last year. She came with a little envelope and she said, I just want to show you what we did. And it was a change in the legislation that it was going to be effective, giving patients in Texas access to fertility preservation. So what you can do, it's very, very powerful.
Yep. Okay, we've got a question from the online viewer, and this one is directed to Dr. Tripathi. In the Illumin-Strana-Bema study, did they look at patients who had ER loss but not an ESR1 mutation? Is it still effective, and could it potentially be used in later lines of treatment? What if there has been a prior RB1 mutation and or loss of an RB allele? Would that affect trying that therapy?
So they did not automatically look at ER loss because these patients weren't always rebiopsied, although more and more now we do rebiopsy them, and if they're ER negative, which happens sometimes, they wouldn't have been on this study in that case. But they did test for ESR mutations. That was part of the trial, and what they showed is that imlunestrant did help patients, or was better for patients with an ESR1 mutation, but was not without an ESR1 mutation. The RB loss question is an important one because RB is the pathway through which the cyclin-dependent kinases operate. And if you're missing RB, inhibition of CDK4/6 won't matter because it's the target of that kinase. So it's not a common mutation. RB loss is quite rare, 1 to 2% of cancers. We do see it emerge when people get CDK inhibitors and become resistant. And then if you look again, now you'll see more RB loss, but it's still not that much. It's maybe 4 or 5%. It's not one of the common mechanisms of resistance. If I knew someone had RB loss, I would not put them on a CDK inhibitor. It's not routinely tested for in first line of therapy, but we know these patients won't respond to CDK inhibitors.
Thanks, Dr. Tripathi. Next question from the audience.
Hi, my name is Jill Canales, and I'm with Memorial Care Cancer Institute in Southern California. I'm also a board member of a nonprofit called the Pink Journey Foundation. And I'm really kind of piggybacking on some of the comments made by some of the other advocates, and it really, I think, I'm not a big pet peeve person. I don't have a lot of pet peeves, but I have one major one when it comes to breast cancer and pharmaceuticals, and that is that I do not understand, and maybe you can give some advice to me and to anybody else in the room who may agree, how the pharmaceutical companies are allowed to advertise in the way that they are on TV. And it's not staying the same, it's growing. I went with my family to see Wicked in the movie theater, and there was a very long ad from one of the drug companies for metastatic breast cancer for very specific patients. And I just thought, you have got to be kidding me. Like, when does it end? We're one of 2 countries in the world that allows drug companies to spend that kind of money to advertise directly to patients. At what end? And I work directly with newly diagnosed patients, and from diagnosis through into survivorship and sometimes into metastatic settings, and they can't afford their medications. And how do we go about, the FDA is coming tomorrow to speak to us, and I want to ask them the same question. How do we, as advocates, where do you even start? Because if I'm sitting at home and I have metastatic breast cancer and I see an ad on the TV for some drug, that's not going to change what my medical oncologist is going to give me. I just find it appalling, and the comments about the big circular, things downstairs that are moving and rotating and all of that, that doesn't even touch the amount of money they spend in advertising to the general public. And it's like, that is my cause right now. Like, how do we lessen that? Because money is being wasted and patients can't afford drugs.
Stumped.
I totally agree with you.
You agree?
The advertising for drugs is, you're right, it's us in New Zealand and that's it. And it didn't used to be that way. It was allowed maybe 10 years ago, I guess, or so, when drug companies were able to start advertising. And it's actually protected by the Supreme Court in the Citizens United case. So anything now can be said. It's free speech. So it's really an interpretation of the law of our land. But I agree with you, and I think that advertising to physicians is also, in my opinion, sort of a shady thing itself too. We shouldn't be advertised to. We should go by the data, and we should listen to the literature. We should listen to, there are some areas that are controversial. Should you use this drug here or not? And we all may have different opinions. But where I want to hear advice from is when I present it at a case review conference with my peers, because that's what we do when we have a controversial case, and I trust that, or I go to the medical literature. But I don't want to hear it from advertisers. So, but it's legal, and so they're going to do it, and it's a shame that so much money is spent on it, and including in all the exhibits here, because we shouldn't have to see it. We shouldn't have to see it, and we shouldn't react to it.
Correct.
Thank you.
Okay, we've got a question from an online viewer. The keynote address today discussed multi-pronged approaches, utilizing multiple mechanisms to challenge the cancer, rather than the sequential pattern that often still dominates, particularly in metastatic disease. Could you comment on this idea?
I think that's definitely the right idea. So if you look at HIV, if you look at TB, you've got to know the drivers and you can block it. And we spend so much money now and so much research, great research, knowing what is called a truncal mutation. Mutations that actually are early on in the disease process. And if we block that, you're going to see less and less need for chemotherapy. And that's what we've been talking about all evening. We're talking about the HER2 therapies, how we now use dual HER2 therapies, and even now more than that, and also for ER-positive breast cancer. So I really think that the combinatorial therapies is the way, if you want to actually maybe even cure metastatic disease, is going to be in combination. Or the ADCs. Oh, ADCs threw everything away, but you get what I mean. So we agree. You agree?
Any other comments?
Yes, I think we have to, it has to be rational though. We have to understand which pathways to target, and we have to guide ourselves by laboratory studies and then test them in clinical trials. Not every combination is going to work. We don't want to be indiscriminate, but we want to be intelligent. And I think that using bioinformatics and artificial intelligence and some of the newer model systems we have is going to accelerate that. So I'm very optimistic about rational targeted therapies.
Absolutely.
Right. Okay. Next question from the audience.
So this is Christine Carpenter again with the Beyond Pink team and the National Breast Cancer Coalition. And I would like to encourage those of you who are disgusted with the way drugs cost and is to, for $35, you can join the National Breast Cancer Coalition. And while we do not have a piece of legislation yet, we are really trying to tackle that problem in an evidence-based and smart way. So I encourage you to join the National Breast Cancer. Go to stopbreastcancer.org and join us. We need your help.
Thanks, Christine. Any other questions from the audience here? How about our panel? Any questions for each other?
This is for both of you. What do you feel are the areas where we need to personalize medicine, breast cancer therapy the most, just in terms of specific breast cancer situations? Where do you think the needs are most urgently if you were a funding agency? What RFA would you put out? Request for applications. You get to write an RFA for $25 million grants.
There you go.
You know, there's so many, there are so many areas where we need more answers, but I think it would be ideal to, in this like wish list, right, to develop and to obtain like real predictive markers of response. So think about early stage, right? What we need is to improve the outcomes of patients so they don't develop a recurrence ever. And if we could identify who are the patients that need more, right? We will save on toxicities, we will save on money, we will optimize our therapy. So I think it will be extraordinary to really get that prediction, right? Not prognosis, because we can get that, but like the prediction. I think that would be my Christmas wish list. And there's super smart people all over the world working on that, because that's I think what's going to lead us to like truly personalized therapies. I don't know, what about you, Jenny?
What keeps me up at night? There's only the one thing which I really don't understand is this increase in young cancers, and that actually we've done really, really well in breast cancer. Mortality from breast cancer has fallen by 40% in the last few years. It's a big deal, but why are young women getting? And I think they're getting ER positive breast cancer. So what are we doing? And this is not the TNBC, we don't understand it. They're getting there in the 20s. I'm seeing it now. And I'm just going like, I'm flummoxed. They're not, you know, you can usually see family history. African Americans tend to get it a little bit younger than TNBC. You're not seeing the usual phenotypes. They're young and I want to know, and I have, frankly, no idea. And it's so humbling, and it keeps me up.
And it's actually happening in other cancer types, right? Like we see a lot of colorectal cancer and lung cancer in non-smokers. So no, you're absolutely right.
What is happening there?
Yeah.
I'm blaming social media, but.
One of the speakers yesterday suggested possibly microplastics.
Microplastics is a common, and then diet, right? A hamburger diet, but it may not be.
Okay. Unfortunately, we're running a little low on time, so this is probably going to be the last question we have here from an online viewer. Has there been any effort to develop a test? Oh, do we have an online? I'm sorry, an in-person?
Yeah.
Go ahead. I'm sorry.
Live person right here.
Live person. There we go. Yeah.
So, Dr. Trapathy, you mentioned what would we do with $25 million. I have an idea. Betty Sanchez here with Living Beyond Breast Cancer and an Alamo Scholar. And I thought about, how can we add on to standard of care practices that include integrative programs like nutrition, exercise, acupuncture.
Definitely.
A lot of practices have now included mental health, patient navigation, and I know it could really help with the care and the medicines. It's going to make medicines maybe act better. So what's any suggestions to bring that into a standard of care practice?
Yes, I think living longer and living better are both goals. So we have to be mindful of that and look at things like integrative medicine. Mindfulness-based stress reduction is a practice that actually has a lot of evidence behind it, both in terms of quality of life, mental well-being, physical well-being. And so there is a building amount of evidence. I've belonged to a society called the Society for Integrative Oncology since its founding, almost 30 years ago now. And it's dedicated to looking at integrative, complementary areas in cancer that can be helpful through the standard evidence that we use. And evidence can be either lengthening of life or improving quality of life. That's just as important. So we need more research in that area. The Office of Integrative Medicine or Complementary Medicine, I think it has a new name now, it keeps changing, is very underfunded. And there's a couple of foundations like the Gateway Foundation that supports research in this area, but we need more. And we need input from breast cancer patients and breast cancer advocates to help chart our agenda. So it's a good question, and I support it. I think most of my colleagues support it as long as it's rigorously done. It should be, done with the standard level of evidence that we require for any medical approach.
Great.
And I will add that there are guidelines, not only some that, like Debu has co-authored, but ASCO has guidelines now, MASC has guidelines, and in that session yesterday of, like sex, drugs, and rock and roll, they had like the first session that it was talking about supplements. It touches on some of the highlights, what are the recommendations for the use of cannabinoids and what of these integrative practices are helpful and which ones of them are actually potentially harmful, because that's also something that we don't want, right? So you will find some interesting references for all those guidelines there.
Thank you so much. Well, unfortunately, we are out of time for the night. I want to thank our panel, Dr. Chang, Dr. Tripathi, Dr. Chavez-McGregor. Thank you. A round of applause. I also want to remind everybody that I thank our sponsors for being able to support our program. We wouldn't be able to do this without all of you. All the patient advocates in the room, all our scholarship recipients, the Alamo Advocate Program Planning Committee, Alamo Breast Cancer Foundation. Everybody, thank you so much. Hot Topics tomorrow night, same time, same place. Please be there. Again, thank you, everyone. Thanks for coming.